start the recording. Okay, so today our topic is schizophrenia. So let's discuss about it. Uh, yeah, sorry for the delay today. Yeah, because I had the recall class a bit later. Then that's it. I couldn't start the session at 10, but tomorrow we will continue our the same time. Okay. So here, what is schizophrenia? So what
Doctor,
is
your screen is not visible.
no, doctor? I still haven't shared the screen, doctor. I'm just like asking you questions.
What the hell?
Okay, so okay, 1 minute. Okay, let's share the screen. Okay. So what is schizophrenia? It's severe psychiatric disorder, right? It's a very severe case. And it is the most common psychotic disorder in Australia. Okay, usually between late adolescent and 30 years of age and more prevalent in males than female. So usually schizophrenia, the age is adolescent and 30 years of age. Okay, because usually the schizophrenia can happen like age of onset is in young age. Okay, not in old age. Okay, old age also there can be, but it's not from from the primary causes. Okay, I'll explain why. So what is happening in schizophrenia? So here we have different hypotheses, right, for schizophrenia pathophysiology. So we have dopamine hypothesis and glutamate hypothesis, right? So what is happening in dopamine hypothesis? In here, mainly due to dopamine imbalance, right? Dopamine imbalance, there's too much dopamine in mesolimbic pathways and that can aggravate the positive symptoms. Don't worry, we will discuss about positive symptoms. I'm just like little bit explaining what is happening in this schizophrenia. Okay, doctors. Yeah. Then, it's a dopamine imbalance, right? Or very little dopamine in mesocortical pathway that can aggravate the negative symptoms. So, if there is a high dopamine and there's a low dopamine also can cause a problem, right? So, that is the dopamine imbalance, dopamine hypothesis. And other glutamate dysfunction, right? Glutamate is a neurotransmitter, right? Usually do the excitatory action, right? So here, low activity of NMDA receptors can lead to the abnormal dopamine release and cognitive problems. And
Ma'am,
serotonin.
from where are you reading this?
Yeah, I'm just like explaining from my
Okay,
university notes. Yeah, I love
okay, ma'am. Okay, ma'am.
pathophysiology. I'm just explaining, okay? Because then it's easy to understand what is happening. This is not very
Okay, ma'am.
important
Okay, ma'am.
for AMC. I'm just like explaining, then it will help eventually. Okay, so yeah, and here, next we have to know about the symptoms, right? Symptoms and DSM-5 criteria here. Okay, here we have positive symptoms, we have negative symptoms, and we have cognitive symptoms. So different symptoms. Okay. So what are the positive symptoms? These are hallucinations, delusions, impaired insight, disorganized thinking and speech. These are the positive signs and symptoms. And negative signs and symptoms are lack of motivation, poor self-care, blunted affect, reduced speech, social withdrawal. And cognitive signs and symptoms are impaired planning, reduced mental flexibility, and patients can have aggression, disorganized behavior. So these are the symptoms in schizophrenia. Okay, so let's go to the DSM-5 criteria. So we should know about it. Okay, so this is the DSM-5 criteria. Okay, here two or more of following each present for a significant portion of the time during a 1 month period or less if successfully treated. At least one of these symptoms must be delusion, hallucination, and disorganized speech. Okay, so you can remember like this. There's a five things you should remember in DSM-5 criteria. So number one is hallucination. Hallucination, and this usually in schizophrenia, the most common one is auditory hallucination. Okay, please remember these things. Okay, auditory hallucination. And the second one, delusions. So we all know delusion means a false fixed beliefs, right? So delusions. And the third one is disorganized speech. Okay, so these main three symptoms are like the most important three symptoms. Here, they have mentioned at least one of these must be delusions, hallucination, or disorganized speech, right? And next one is grossly disorganized or catatonic behavior. So, disorganized behavior. Then the last one is negative symptoms. Negative symptoms like alogia, that mean lack of speech, evaluation, mean inability to initiate, right? And anhedonia, loss of interest, and then affective defects. So much things you can see in negative symptoms, right? So we have positive symptoms and negative symptoms, cognitive symptoms. But DSM-5 criteria mainly they focus hallucinations, mainly auditory, then delusions and disorganized speech. Third one, the fourth one, disorganized speech, so disorganized behavior. Then negative symptoms, okay? Hallucination, delusion, disorganized speech, disorganized behavior or catatonic behavior, then negative symptom. And you should know this thing. So continuous signs of the disturbances persist for at least 6 months. And this 6 month period must include at least 1 month of symptoms or less only if treated, okay? Less if only treated that meet above criteria and may include periods of prodromal or residual symptoms. Yeah, that is the DSM-5 criteria. Okay, the symptoms must be how long? At least 6 months, and it must include at least 1 month of symptoms, right? If it is less, if only treated. Okay, don't worry, you will understand it when we do the question. Okay, and other than this, we categorize these symptoms to, as I mentioned earlier, positive symptoms, negative symptoms, and cognitive symptoms. Positive hallucination, delusions, disorganized speech, disorganized behavior, thought disorders, right? Negative symptoms, same thing, apathy and hedonia, evaluation. Okay, then cognitive symptoms, memory issues, impaired perception, and attention problems, right? And patient can't make the decisions and everything. Okay, so these are the symptoms. Then, and this is the DSM-5 criteria. Okay, then the next most important part is treatment of schizophrenia. Okay, when we decide in the treatment, we should know if this is the first episode or this is the relapse or like that. Okay, usually you have to think what situation is this first. Let's treat the first episodes of psychosis. Okay, this is the first episodes of psychosis in this patient. Here, principles of treating the first episode of psychosis in adult and young people. Okay, give me 1 minute. Okay, so here the principles in this topic apply to the acute treatment of first psychotic episodes. Doctors, can you please keep your mic muted? Okay, then here, ideally, first episodes of psychosis should be managed by a specialist and urgently refer patient to the psychiatrist or mental health service because early treatment reduces the period of untreated psychosis and improve the outcomes. Okay, this first episode should be treated by the specialist, and we have to refer this patient urgently for the psychiatric assessment because early treatment can prevent more dangerous outcomes. Okay, then evaluation whether admission to hospital is needed. These are the considerations. The risk of harm of the patient poses to themselves or others, the patient's level of insight, and so what is insight? So what is insight, doctor?
The patient is known that I have some diseases.
Mm-hmm. Yeah. Insight mean like if the patient is having some awareness of their disease, right? If there's no insight, mean there's no awareness, right? And there's okay, no, not now. After schizophrenia, we have one question in November about some yeah, not now. Okay, after this, I will show the question and explain it. Okay, and in that question, they have asked about the reality testing because the patient is suspecting schizophrenia or psychosis. So I'll explain then what about this insight. Then availability of the community mental health resources and family or other social support. So then treating agitation in adults and young people with psychosis. Okay, here agitation is common in acute psychosis but usually settle within days. If a patient with psychosis is acutely agitated, only provided treatment if is safe and appropriate to do so. If possible, use non-pharmacological measures including verbal de-escalation and psychological intervention to reduce the risk of harm. Okay, patient is presenting with first episodes of psychosis and patient is agitated. So if they ask what we should do first is giving diazepam or is doing verbal de-escalation. So what we should do? Tell me your answer. Yeah, first we have to try the non-pharmacological measures, right? So non-pharmacological methods like verbal de-escalation we can use. Okay, so if the non-pharmacological methods fail to, like, this is an acute situation, right? Patient is agitated, so we have to first think like that. When a patient with the psychosis come and he's agitated, and we have to do something to calm down, right? Then after we can treat the actual disorder. First we have to calm down this patient. For that we can use as the first thing if there's a no harm, okay, no harm to doctors or other doctors or themselves like patients, first we can use non-pharmacological measures like verbal de-escalation, okay, to reduce the risk of harm. If a patient with psychosis remain agitated but is willing to accept the oral sedative, okay, we have tried non-pharmacological methods like verbal de-escalation, and patient still agitated but patient is accepting oral sedative, okay, patient is okay with something to drink, okay, some tablets to take. So in that case we can give diazepam 5 to 10 milligram orally every 4 hours if required, up to maximum dose 40 milligram in 24 hours. Continue for up to 1 week, or lorazepam 1 to 2 milligram orally every 4 hours if required, up to maximum 6 milligram in 24 hours, and can continue up to 1 week. So in that case, patients non-pharmacological verbal de-escalation not working, patient agitated, and patient is okay with taking oral sedative. So in that case, diazepam, lorazepam, the best options. Then, when selecting suitable diazepam and determining its dose, consider patient's factors such as level of agitation, body size, age, sex, comorbidities, treatment setting, drug history. Okay, we have to think about everything, and treatment response, and whether patient is pregnant or breastfeeding as well. Most benzodiazepines doses should not use initially in patient treated in the community, particularly in those who are benzodiazepine naive. If diazepam or lorazepam cannot be used, then what is in the chat? Yeah, doctor, I will send. Uh, we have different PDF for this one, okay? The schizophrenia, because we have one treatment for the first episode like that. I'll send it, okay? Then, okay, yeah. Here, if diazepam or lorazepam cannot be used, use suitable dose of patient's antipsychotics as required, but do not exceed the maximum dose of antipsychotic, including regular doses. Okay, we will check about antipsychotic later. However, there are few data to support as needed administration of antipsychotic, and it can worsen the agitation and increase the risk of adverse effect. After the agitation has resolved, do not continue antipsychotic at the increase due to the manage of the disorder. Okay, then if the patient remain acutely agitated at the risk of harming themselves or others, like 30 to 60 minutes after the administration of benzodiazepine or antipsychotic, or if the patient will not accept oral sedative, then what we should do, okay? Here, there's a pharmacological management of acute behavioral disturbances in adult. Okay, let's check it. Here, I have shared this PDF, okay, acute behavioral disturbances, because we were supposed to discuss this in one day, but I couldn't do that part, okay? So here, 1 minute. Here, the same thing, they have oral regime, diazepam, lorazepam. Okay, if the oral one is not working, here, minute. Okay, don't worry, I have my PDF. Yeah, because sometimes, okay, here for the acute behavioral management, okay, because this is the acute situation we have to here. Yeah, Okay, here as I mentioned, non-pharmacological de-escalation, the first line, quiet, low stimulus environment, verbal de-escalation, address unmet needs, pain, hunger. So we have to first thing, the non-pharmacological de-escalation. Okay, here. Then consider pharmacological management only if non-pharmacological methods fails or there is a imminent risk of harm. Okay, there's this chart. And we have, I don't think we should discuss about this chart today, but it's fine. We have sedation assessment tool, okay, SAT tool, because before we are giving the sedation, we have to assess the
Oh, boleh.
patient.
Oh, boleh.
No,
Oh,
doctors,
boleh.
please.
Boleh, boleh. No, no, no.
Okay. We have to assess this patient. Okay, according to SAT score only, we decide what we should give. Here, this is the SAT score. Okay, I have shared this document. Usually, this the even in first line psychosis and first line acute behavioral, everything is like same. Okay, because acute situation, right, we have to calm down the patient. So for that, like for even for delirium and everything, it's kind of same, especially for when we using benzodiazepine. Okay, but not antipsychotic. This is actually for the benzodiazepine usually. So here, this SAT score, we have different things for the responsiveness and speech. If SAT score +2 or +3, there's an imminent risk. So +3 mean combative and violent and out of control. The speech continuous and loudly, they're shouting like that. If +2, very anxious and agitated and same loud outburst. Okay. So in those cases, we need to urgent intervention. Right. So usually we have to think about this SAT score as well. And yeah, here pharmacological management. The same thing. Okay. We'll go back to that topic because if we're going to discuss this one also SATSCO and everything here, it will be hard. For now, just remember like this, okay? The simply, I know that this one is very hard, okay? This one like psychotic management because we have acute behavioral thing. Usually acute behavioral disturbances that SATSCO and everything, they are mainly for diazepam administration, okay? But don't confuse with this here. First thing first, if there's an acute psychosis, first episode present, first thing first, non-pharmacological de-escalation. Then, if the patient is still agitated and patient is like to take oral sedatives, we can give. Okay, if after sedatives or if there is like some contraindications or something like that, we can't give benzodiazepine. In that case, we have to consider antipsychotic. Okay. Do you remember? We just read that part here. Yeah. Where was that part? Here, here. If diazepam or lorazepam cannot use a suitable dose of antipsychotic. Okay. But this also can agitate the patient. That's why benzodiazepine is better. And this is the second one. Okay. Yeah. Then after that, if the patient is like even after these antipsychotic, diazepam and everything, this patient remain acutely agitated and risk of harming for 30 to 60 minutes, then we can refer this patient here, consult a psychiatrist to consider suclopenthiazole acetate if the patient has any of following features. Inadequate response to the therapy, disturbed behavior for an extended time, like 24 hours to 48, then history of good response to suclopenthiazole acetate or history of requiring repeated administration of intramuscular for acute behavioral disturbances. So these are the indication for this drug. Okay, recurrent agitation and aggression is likely to continue for next 2 to 3 days. If appropriate, a psychiatrist may use this drug. Okay, and sucralfentizole acetate has an onset action within 2 hours, and the peak effect is achieved approximately 24 hours of administration. A patient should monitor after receiving this drug. Then, then let's discuss about antipsychotic choice for first episodes of psychosis in adults and young people. If antipsychotic therapy for first episodes of psychosis is considered necessary after observation of the patient for 24 to 40 hours, if possible, discuss the following with the patient and patient's consent, their family, care, and significant other. The purpose of the antipsychotic therapy and its place in multifaceted treatment, which antipsychotic adverse effect is acceptable to the patients and how these effects are monitored. Okay, so before that we have to explain about antipsychotic. Okay, then usually we have to calm down the patient. Then after, anyway, the mainstay treatment of the schizophrenia is antipsychotic, right? But in acute situation, we should prevent it. We mainly use non-pharmacological verbal de-escalation and benzodiazepine. But in some cases, we have to use these antipsychotics as well to control acute situation. But usually after calm down the patient, after controlling acute situation, we have to make sure the patient is getting good antipsychotic therapy for their long term prognosis, right? Yeah. And before deciding the antipsychotic therapy, patients should have so we have to assess the patient's like adverse effect and patient's other comorbidities like cardiovascular risk, because some drugs of antipsychotic are having some cardiometabolic effects, and some drugs have extrapyramidal adverse effect. Like we have different and anticholinergic effects. So we have to assess the patient right before starting the antipsychotic therapy. And okay, then antipsychotic regime for first episodes of psychosis in adult and young people. So, here to treat the first episodes of psychosis in adult or young person, we can use amisulpride, aripiprazole, quetiapine, and quetiapine. We have immediate release and modified release, and risperidone, ciprasidone. Like we have so much drugs, okay, but we have to decide according to the patient's situation. Okay, so don't confuse with this word, okay, antipsychotic regime for first episode. They are talking this like after managing the acute situation, okay, not for the acute situation. So always you have to follow the acute situation protocol, okay. Diazepam and non-pharmacological verbal de-escalation. Then after calming down the patient only, we have to decide what we should give for this patient, because the mainstay treatment is antipsychotic. So in that also we have different types of antipsychotic. So let's check principles of antipsychotic use. What is this? Not this one. Okay, here. Antipsychotic has been classified in different ways: typical and atypical, first generation and second generation. But these classifications are not pharmacological meaningful and not used in this guideline. The dose of antipsychotic required to achieve the best balance of effectiveness and adverse effect varies considerably between individuals. The same thing that I have mentioned. And using higher than recommended doses are rarely improves the symptoms, but it associated with increased risk of adverse effect. However, psychiatrists may exceed the recommended dose range in patients with treatment-resistant schizophrenia, and increase the dose of olanzapine may be used for short-term. we'll discuss after this treatment-resistant schizophrenia. Okay. Before that, let's discuss about the adverse effect. Okay, adverse effect is a very high part. So, what are the adverse effect of antipsychotic drugs? This is a very high part, okay? Because in most of the time, they are asking in every month at least one question from these adverse effect. If you are familiar with recalls, you know, right, uh, how they have given this one. And here, before starting antipsychotic therapy, the same thing, we have to inform the patient about the adverse effect and everything, and we have to take the consent as well. And here, during the antipsychotic therapy, we have to regularly monitor for adverse effect and regularly remind the patients to eat a healthy diet and undertaken physical activities. Regularly ask about smoking and if relevant, encourage smoking sessions. So we have to monitor this patient, okay, because they have like very large amount of adverse effect. So let's talk one by one, okay. So we have anticholinergic adverse effect, cardiometabolic adverse effect, and acute dystonia, Parkinsonism, and tardive dyskinesia, akathisia, hyperprolactinemia, and neuroleptic malignancy syndrome, orthostatic hypotension, QT prolongation, and sedation. Okay, in November, they have asked from this sedation and what else, doctors? And cardiometabolic effects, right? As I remember. What are the doctors? What about doctors? Dr. Mefta, Dr. Bhagya, what do you think? You were there? Dr. Ritik, you were supposed to revise everything, right? Then you should remember. Okay, I'm just, yeah, yeah. As I remember, we got sedation and cardiometabolic adverse effect. Okay, so let's go one by one. And there is a chart, okay, here. It's a good one. And you should, I will send this, don't worry, okay? Yeah, this is a good one. You can use this one, okay? You should normally, in the exam, they are asking questions like, as example, patient is taking risperidone, okay? Patient is taking risperidone and after a few weeks, patient gain the weight. Here, okay, let's go. Then what we should do next here? As risperidone. Here risperidone. So you can see the cardiometabolic effects of not yeah here. Okay, risperidone. The cardiometabolic effects are 2+, right? Here 2+. Then they are asking. So in that case, what we can do like that? Okay, so in that case, you should know what are the less effect for cardiometabolic. So you can see aripiprazole having -2 plus or amisulpride +1, right? Then sometimes they can ask about the extrapyramidal effect. In here you can see the quetiapine plus or minus good and aripiprazole like +1. Usually the aripiprazole is a good drug for every side effect. You can see here anticholinergic effect +2 minus here, the same cardiometabolic also extrapyramidal +1, hyperprolactinemia, no. Orthostatic +1. This is a very good drug, the aripiprazole one, okay? And quetiapine also good, but not in every cases, right? Here you can see it has the anticholinergic effects. It has higher effect of cardiometabolism. Extrapyramidal also good, hyperprolactinemia this also good, and others have higher effects. So you should remember this, especially for aripiprazole, then clozapine, haloperidol, then olanzapine, quetiapine, risperidone, and ciprasidone. So please remember these adverse effects for these drugs. So amisulpride, aripiprazole, then clozapine, then haloperidol, olanzapine, quetiapine, risperidone, and ciprasidone. So please remember, okay? I'll take the screenshot of this and yeah, I'll send this one as well. Then you will remember. So please, this after I send this screenshot, please highlight these drugs: amisulpride, aripiprazole, clozapine, then haloperidol, olanzapine, quetiapine, risperidone, ciprasidone. So you should know what is the best drug for if there is extrapyramidal effect, if there is a hyperprolactinemia. So we will do questions, then you will understand. Okay. I know this topic is kind of hard, but you have to do it. The same thing they have mentioned in here. That was the small chart. Anyway, you have to do hard work to remember this one. Okay. Uh, the only thing I can do is like tell you have to remember these things. Otherwise, I can't help you. Just you have to memorize this chart. Okay, like that. These are the adverse effect. Okay, the same thing. Okay, yeah, the same thing. We have to measure weight, waist circumference, BMI, ask about the extrapyramidal effects. So, same thing they have mentioned. Don't worry, I'll send each PDF. Then you should know. Now you know what are the types of antibiotics we can use. And you know how we should switch between antibiotics. Like antidepressant, do you remember? You should know the adverse effect, right? Then you should know how we should switch this, right? Okay, so let's check
Yes,
how
ma'am.
we, yeah, let's check how we switch antipsychotic. In here, the advice in this topic is to support the practical implement of the antipsychotic recommendation for adults and young with here bipolar and psychotic disorder. So like all of these in bipolar also we use antipsychotics, right? We haven't done the topic, but we have to do. It's a very high yield topic. So in these are overall they are going in like same way, okay, because they are using the same drug. So like everything is same like antipsychotic, because we use in different cases, right? Not in schizophrenia, not only in schizophrenia, right? Here, a switch of antipsychotic may require because of poor treatment response or adverse effect of patient's request. If a switch is being considered because of poor treatment response, so if there's a poor treatment response, we have to first check whether the poor response can be explained by the factors. Okay, let's check what are the factors they are given. Yeah, not response to antipsychotics. So we have to check, is this diagnosed correct? Have possible medical cause of their symptoms has been identified and treated? Have alcohol or other substance use prodrome? Because as do you remember, I have mentioned while we are giving the antipsychotic, we have to monitor this patient's alcohol consumption and smokes, right? If the patient is smoking or not, like everything is affecting his treatment response, right? Has the patient been treated with adequate dose or antipsychotic for adequate duration? Is the interacting drug reducing the response? Is the patient adherent to the therapy or not, right? It's a very good question. We have to check patient is taking the proper dose in proper uh, mentions a period, right? Yeah. And is the patient experiencing adverse effect? Okay, like that. Yeah, then okay, we'll go back to that switching part. That, yeah, here. Okay, then if non-adherence is identified as the cause for poor treatment, determine the barrier to adherence. So we have to check the why this patient is not adherence, right? In that case, these barriers may be focus of treatment. Example, addressing the factors contributing the non-adherence or guide the subsequent antipsychotic selection. If there is a adverse effect, we have to select another one like that too. If negative symptoms of psychosis are inadequately treated, see them. Yeah, we will go back to later that. If the treatment response is adequate but the patient experiencing adverse effect, first thing non-adherent, then patient is adherent but the patient is having adverse effect. Yeah, sure, doctor. Don't worry, I will send it. Okay. Patient is having adverse effect. So we have to select the proper drugs. Okay. Let's check what they have given here. Same part. That's a that's a problem in therapeutic guideline. Sometimes like it's a very weird place to use. Okay. So then adverse effect. Then before switching antipsychotic, discuss the potential harm like relapses, temporary exacerbation, or adverse effect and benefits. Then, if the decision is made to switch antipsychotic, the switch should ideally occur in collaboration with the patient's psychiatrist, mental health team, or practitioner experienced in switching. And preferably switch antipsychotic with different dopaminergic receptor occupancy profile, like adverse effect. So we will do the question, then you will understand. Okay, I know now you can't understand anything. No, you can understand, but you have no idea what is the order, like why we are switching now. Like I know the problem, but it's not a hard topic. Okay, we should know the basics only. Then we have to plan the switch and decide the outcome that will determine. So the usual thing decide. Then the speed and switch between oral antipsychotic depend on the pharmacokinetics of the antipsychotic. And then where the patient is acutely unwell or stable, then setting in which the switch to undertaken like hospital or command. Okay, better if we switch bit in the hospital. If the patient are acutely unwell in hospital, the fast switch may be used. However, this increases the risk of adverse effect. Yeah, then for patients who are stable in community, slow reducing the dose of the first antipsychotic while simultaneously increase the dose of the second antipsychotic, reduce the risk of adverse effect. This is the best way, okay? Not like abruptly stop. So we can reduce the first antipsychotic dose, then we can at the same time so we can start the other antipsychotic from low dose, right? Then, switching from oral to long-acting injectable antipsychotic, yeah, they are not asking from like these doctors, like injectable things. You should know mainly the adverse effect, how you should manage in acute cases. Then, how you should decide the antipsychotic adverse effect, like that.
Provided that we people give
Oh my
bring and come, they go give.
God. Oh my God, can't keep mute every time. Okay, then recovery and relapse prevention. Let's read that. Principles of recovery and relapse prevention in schizophrenia. So, continue antipsychotic therapy for the adequate duration after it. Adequate duration after psychotic episode, right? We should use adequate duration usually. And continue antipsychotic therapy for the adequate duration after psychotic episode for and for duration of antipsychotic therapy first. Yeah, let's check the the duration. Okay. The duration of antipsychotic therapy for the first episodes of psychosis. If the this is high doctors, this part, okay, please take a screenshot. If the symptoms at least for longer than 6 months, okay, 6 months, or the patient has delusional disorder, continue antipsychotic therapy for at least 2 years after symptoms resolution. So, what are the indications? If the symptoms last more than 6 months or patient is having a delusional disorder. So, in that case, we have to give 2 years of treatment even though patient is symptoms free. Then, if symptoms resolve in less than 6 months and the patient does not have delusional disorder, continue antipsychotic therapy at least 1 year after symptoms resolution. Okay, I'll send this one as well because they are asking about this part. Okay, so here, please remember what are the. So, okay, I'll show. So, delusional disorders are grandiose, persecutory, erotomanic, somatic. We have different delusions, right? So, if this one of present, so we have to still continue the treatment for at least how long? 2 years. Like if patients' symptoms resolve in before 6 months, then 1 year is enough, right? So please remember this. Okay, yeah, it's a very high. Then, okay, we have okay here. Okay, so we know the duration as well. And do not use intermittent therapy like drug holidays. So please remember, okay, we should not use intermittent therapy like we should not give the drug holidays during the treatment because restarting an antipsychotic in early relapses is not as effective as continuous therapy. So best continuous therapy. And the most patients who recover from the first episodes of psychosis experience relapses. Relapses is usually associated with poor adherence or stopping antipsychotic therapy as part of the treatment plan or other contributors to relapses. So here, what is this? No need about the injectable one. Yeah. So you know what are the drugs, adverse effect, and the duration, right? Yeah. Then what else we should know? Okay, we'll go back. Mhm. Okay, relapse management. Okay, we have assess. Okay, let's discuss. Most patients who recover from the first episode psychosis experience relapses. We know that. Okay. Relapses usually associated with the poor. Yeah, the same thing we discussed, right? Ideally, a relapses should be managed by patient's psychiatric or mental health team or experience consultation. The same thing, doctors, they have mentioned in here. Okay, a treatment of relapses must be multifaceted or individualized. Yes, depend on the patient's situation, on what is the patient's drug adherence. So we have to check everything, right? Because patient is already in antipsychotic therapy and relapse can occur. We have to check whether why these relapses occur. Then start treatment as soon as possible to improve the outcomes and continued antipsychotic therapy is the key components of treatment of facilitate the recovery and prevent suicide. The choice of antipsychotic therapy for the relapses depending on the cause. Okay. Yeah, the same thing. We have discussed how we assess. Generally, we discuss everything, but I don't want to miss anything from here. That's what I'm just reading this. Okay. If relapse occurs after planned antipsychotic discontinuation, this is a planned one. We have to restart the previously effective antipsychotic aiming for previously effective dose. Okay, so these two are good points. If relapses occur after planned antipsychotic dose reduction, you have to increase the previous effective dose. If non-adherence is the likely cause of relapses, we have to determine the why this patient is non-adherence. We discussed that part. So here, please remember this one as well about the relapses. 1 minute. So I'll take screenshot of most important part. Otherwise, you will be like you never like the schizophrenia. Okay, but in the finally we will discuss again. Let's check what else we have. Okay, let's go through negative symptoms, what they have mentioned. Then managing negative symptoms in psychosis, including schizophrenia. So here, negative symptoms are a significant cause of long-term disability because they respond poorly to treatment with most antipsychotic. Okay. Then ensure antipsychotic therapy is optimized and take the following step to address negative symptoms. Assess if negative symptoms are an antipsychotic adverse effect, like sedation, right? Do you remember we had the sedation as the antipsychotic adverse effect? Then assess for and treat the comorbidities, like if the patient present depression, anxiety, apnea, like that, then optimize the patient's engagement with their family and community, because this patient need the family support. Negative symptoms like patient is having no emotions, always like very negative, right? So and loss of interest, everything is happened, so we have to address them. Yeah, doctor, I will upload, don't worry. I know. Okay, then if negative symptoms persist despite of the interventions, contact the patient's psychiatric advice. So in this case, patient is in depressive mood, right? Like negative symptoms, we know loss of interest, loss of emotions, everything is negative. So in that case, we can do the psychological interventions as well, like cognitive behavioral therapy, like that. Okay, in that case. So that's all for negative symptoms. The last one is uh, treatment resistant schizophrenia. Okay, let's check about it. It's also high. As I remember, we got one question in October recalls, but I'm not 100% sure. Let's check. So, treatment resistant schizophrenia. In here, up to 40% of patients with schizophrenia experience residual symptoms even when clinical stable and adherence with the optimal antipsychotic therapy. Here, if a patient considered to have treatment-resistant schizophrenia, if they meet all of the following criteria. So, this criteria you should remember, okay? These criteria, so 1 minute. This is also height. Okay, I have screenshot the most important points and I'll send that adverse effect and everything as well. So, here, moderate or severe positive, negative, or cognitive symptoms for 12 weeks or longer. Okay, meet all criteria, not one here, all criteria. Then, next one, moderate or severe functional impairment. Then, third one, monotherapy with two antipsychotic given at adequate dose. like a dose equivalent to 600 milligrams per day of this example chlorpromazine for at least 6 weeks each. So this part is very high, okay? Because if they have given some scenario and if you want to treat this as the resistant schizophrenia, you should know the criteria. Then you can diagnose this as the treatment resistant schizophrenia. Okay. So these are the four criteria that you must remember. Yeah. Here, an adherence to the antipsychotic therapy taken at least 80% of the time as demonstrated by two sources like pills count or but we need true sources like pill counting or checking the antipsychotic blood concentration. We have to confirm by two sources from this patient's adherence. Okay. So what are the four criteria? Moderate or severe positive, negative, or cognitive symptoms for 12 weeks or longer. Please remember 12 weeks or longer. And moderate or severe functional impairment, number two. Number three, monotherapy with two antipsychotics given at adequate dose. As example, dose equivalent to 600 milligram per day of chlorpromazine, at least for 6 weeks each. Okay, one drug should be given for at least 6 weeks, and a monotherapy with two antipsychotic in adequate dose. Then adherence to the psychotherapy, and we should confirm this adherence by two sources. As example, we can count the pills if we actually take the proper amount of pills, or we can check the blood concentration of the drugs. Okay, yeah. Then and patient with treatment resistant schizophrenia must be reviewed by the psychiatrist. And here, if the patient has treatment resistant schizophrenia, refer to psychiatric review and clozapine may be indicated. So you can remember this as treatment resistant, like clozapine, like the close in one, right? Because nothing is work, the last option. Like remember it as the clozapine. Close in one, I remember it like that. Okay, yeah, clozapine, because I have sometimes otherwise I have a doubt with olanzapine or clozapine like that. So in that case, remember the close, the last option, because other treatment are resistant. So we have to close with clozapine like that. We have to close the schizophrenia with clozapine. Okay, remember like that. Yeah, okay. Yeah, that's yes. You can read it later, drug dose and everything. You don't have to remember everything, but you should know the basics. Okay, let's do some questions, then you will understand. Yeah, Doctor, don't worry, I'll share this. I know so many doctors has a problem. Okay, no, we will do the questions, then we will discuss from the questions. Okay, give me 1 minute. This topic is not hard. Actually, you need some a short note kind of thing. Okay, you need to make your own notes. Then it will easy. Otherwise, it's very hard to read from that therapeutic guideline. Okay, you should know DSM-5 criteria, how we should calm down the patient as the first thing. Then what is the first line antipsychotic therapy, then what are the duration, then what are the adverse effects, so you should know that table. Then how you should switch the antipsychotic one from another, then how to decide what is the treatment resistant antipsychotic therapy. Okay, like that. If you have like something special like a note or something, then it's not be a problem for you. And please remember me, before closing the today's topic, we have to do the have to get idea about schizoaffective disorder and schizophreniform disorder as well. Okay. Yeah, we have 24 questions. Like, give me 1 minute. I have to sell it. Yeah, and we have one more topic, extrapyramidal side effect. It's something, yeah, special. We have to do that as well because there's something we have to remember. Doctors, you can take 5 minutes break while I'm selecting the questions and everything. Okay. It's the time now. It's 11:32. We will meet after 5 minutes. Okay. You can take a break. Hello, doctors. Yeah. Okay. Before doing questions, we have something to do. Okay. First, listen. Okay. So, who can tell me what is brief psychotic disorder? Tell me what is brief psychotic disorder because you should know these terms. You should know about brief psychotic disorder. Doctors? Yeah. So, brief psychotic disorder, you can remember from the name, the brief, right? It's like the psychotic symptoms, sudden onset psychotic symptoms, like what are the delusions, hallucination, or whatever. But the duration here is more than 1 day, but less than 1 month. Usually, you can remember it as less than 1 month. Okay. Then next one is schizophreniform disorder. So what is schizophreniform disorder? This disorder has the symptoms same as schizophrenia, right? But the duration is less than 6 months, more than 1 month, and less than 6 months, right? It's a schizophreniform disorder. So you should know these terms because, Mhm. Yeah, good. 1 month to 6 months. Then what is schizoaffective disorder? You can see schizoaffective. Affective means mood, right? In these patients, they have psychotic symptoms and mood symptoms both, right? Yeah, mood symptoms. In that case, usually in schizoaffective disorder, usually like mood symptoms are more prone, but it has psychotic symptoms as well. Okay, and we have one more thing to discuss about these extra pyramidal side effects of antipsychotic because it has something special we should remember. So these are extra pyramidal side effects are acute dystonia, Parkinsonism, and tardive dyskinesia and akathisia. So you should know how if the patient is presenting with acute dystonia while taking some antipsychotic, how we should treat these patients like that. Okay? Sorry. So let's one by one. So what is acute dystonia? Tell me what is acute dystonia?
A brief muscle contraction.
It's a brief muscle contractions, right? Resulting in twisting movements or abnormal postures. Dystonia often affect the face, neck, trunk, but can be focal, multifocal, segmental. So, what we can see in eyes, what the most famous one in here, it's a oculogyric crisis, right? I'll show a picture. Please remember that, okay? Here you can see oculogyric crisis. Here in eyes roll up and patient unable to look down, right? So please remember this one under acute dystonia. Okay. Then here antipsychotic induced dystonia occurs more often in young males. And here how we should treat this antipsychotic induced acute dystonia. We have to stop or reducing the dose of dopamine antagonist. So what they have mentioned in here, As example, our patient is taking, as example, okay, risperidone, and patient is taking metoclopramide as well. Okay, patient is taking risperidone and metoclopramide for some other nausea, vomiting, or something. So, in that case, and patient is presenting with acute dystonia. Okay, acute dystonia. So, in that case, they are mentioning here we have to stop or reduce the dose of other dopamine antagonist. Okay, in that case, it's best we can stop this metoclopramide. Okay, metoclopramide, and we have to check if the dystonia is still present or not. If it is still present, then we have to think about reduce the antipsychotic dose. First, we have to approach the other drugs. Okay, the other dopamine antagonist drug if the patient is taking some other drugs with antipsychotic. Then we have to first thing first reduce the antipsychotic dose. Okay, if it is not working, then we have to switch to antipsychotic that less likely cause the extrapyramidal adverse effect, right? If the above measures are ineffective or impractical, the last option is what? The last option is we have to treat this dystonia. Symptomatic treatment is benzotropine. So, you remember, so please don't keep a confusion because I know when reading this stop in or reduce in dose of other domain then again have reduce and so I know. So please clear the confusion. Please remember that example if the patient is taking risperidone and patient had to take some metoclopramide. So in that case, patient present with acute dystonia. First, we have to stop this metoclopramide or reduce this. Then, if it is not working, then we have reduced the antipsychotic dose. It also not working, then we have to switch for the best one, like aripiprazole. We have to switch this to the good one. Oh, the last option is nothing work. We have to treat this dystonia, right? So in that case, we have to give benzotropine, right? Yeah, benzotropine. We have to give. Then next one is Parkinsonism. So what is Parkinsonism? So what does mean Parkinsonism? What is it, doctor? Tell me. Sorry. Why you are silent today? Ah, okay, you have. Okay, so I just. Mm-hmm. Yeah. In Parkinsonism, patient is having postural problems, bradykinesia, right? Rigidity, resting tremors, right? So much things we have in Parkinsonism, okay? When patient is some patients taking antipsychotic and this antipsychotic can cause this Parkinsonism. In that case also, here we have to follow the same pathway. Here is stopping or reducing the dose of the other dopamine antagonist, then reduce the antipsychotic dose, then switch to antipsychotic less likely to cause extrapyramidal adverse effect, like a good antipsychotic. And the last option, nothing works. We have to treat this Parkinsonism. So the treatment is benzotropine. So remember. Then next one is tardive dyskinesia. So what is tardive dyskinesia? So what is tardive dyskinesia? What is it, doctors? It's a chronic movement disorder characterized by repetitive involuntary choreiform movements. Right? They have involuntary, repetitive, usually orofacial movements like lip smacking, chewing, tongue protrusion. So these are the symptoms here. Tongue, lips, mouth usually affect and can affect the any part of the body, but usually mainly it affects the orofacial movements. Tardive dyskinesia occurs after chronic use of antipsychotic. Here also the same, but one thing is different. Okay, here's the same thing. First, we have to stop the other drug, then reduce the antipsychotic dose, then switching to good one. Oh, there's no symptomatic treatment here. If nothing is work, we have to refer these patients. So please remember, in this case, we have to refer this patient. Okay? So please remember, there's no drug. Then next one is akathisia. So what is akathisia? Akathisia means the patient is having urge to move, right? Due to that, patient is having restlessness and here urge to move, an uncomfortable sensation because always patient want to move, right? So this also can be due to chronic use of antipsychotic. In that case, what we should do here, the treat antipsychotic akathisia. Here, they reduce the antipsychotic dose until the akathisia disappear, or if this is ineffective or not possible, we have to switch. In here, they directly mention we have to first decrease the dose. Okay, first decrease the dose of antipsychotic. Like same here, also here. Here, what is here? The reduce one. They in that case they haven't mentioned about the other drugs directly. They have mentioned the reduce the antipsychotic dose, but you have to consider that as well. Okay. So here the same thing, we have to reduce the antipsychotic dose. If not working, we have to switch. Oh, nothing is work. Then what we should do? In that case, we have to treat these symptoms. We can give propanol, clonazepam or diazepam or mirtazapine. And here, akathisia is abnormal and no. Here, a child develop akathisia. Refer. If the child is developing akathisia, we have to refer. Okay, please remember. And for adults, we can give propanol, clonazepam, diazepam, or mirtazapine. Okay, but we have to follow this stepwise. Okay, stepwise order. First, if there is another dopaminergic drug, we have to stop that first. Then, if it is still having this extrapyramidal side effect, then we have to think of reduce the usual antipsychotic dose. If also not working, then we have to switch. The last option, we have to treat the symptoms, but not for the tardive dyskinesia. In tardive dyskinesia, we have to refer this patient. Okay, that's all. So let's do some questions. A 72-year-old woman, you have to answer quickly, okay? We don't have much time. A 72-year-old woman present to the GP practice clinic with 2 month history of progressive tremors and stiffness. She has a history of schizophrenia, hypertension, type 2 diabetes mellitus, and GERD. Her medical medications include haloperidol, metoclopramide, chlorpheniramine, verapamil, and metformin. She lives independently and does not smoke or drink alcohol. Examination appears well with vital signs with normal. She has a resting tremor of both hand, cogwheel rigidity at the wrist, and reduced an arm swing when working. Her gait is slow with short step. Which one of the following medication is most likely to have caused these symptoms? Is it haloperidol, metoclopramide, prochlorpheniramine, verapamil, metformin? So, what is this? Mm-hmm. So, what is the answers, doctors? You have to type. Okay, let's check you are correct or not. Okay, are you sure? Let's check. Yes, good. Now you know, right? I'll show it again. Okay, because that's why. Here, haloperidol. Here, plus 3 extrapyramidal effect. That was Parkinsonism right here. So that's what I told you. You have to remember this chart, okay? We don't have to read it, right? Then, sorry, a 24-year-old woman present to the ED with constant restlessness and inability to sit for the past 3 days. I already have eye problem, doctor. And I think that will worse. I can't see these words and letters. Okay, that's why I'm reading something else. I have to check my eyes again. She ha because I'm spending most of the time in front of my laptops, right? I should take some glasses for that as well. She has schizophrenia, was started on risperidone 2 weeks ago. She takes no other regular medications and she appears distressed and states that she has uncomfortable urge to keep moving and she denies any suicidal thoughts. On examination, she appears agitated with vital signs within normal limits and she is unable to remain seated during the consultation, frequently standing up and pacing. There's no rigid or tremor. So, what is this, doctors? Yeah, doctor. Yeah. I'm glad Dr. Min said also having the same thing. He's in my boat, right? Okay. Yeah, so yes. Who marked my screen, doctor? Yeah, you know now, right? That's what I told you that extra pyramidal part is very high yield. Okay. Yeah, thank you so much, doctor. Okay, so next one. Yeah, a 26-year-old man present to the ED accompanied by his concerned partner. She reports that over the last month he has stopped leaving the house and often comment that there are bad people looking for him. She is worried that he has been isolating himself and that he will lose his job. He has history of schizophrenia diagnosed 6 months ago and was initially started on oral olanzapine twice daily. This provided good control of his symptoms and initially, however, on the further questioning. He admits that he has only been taking the medication intermittently over the last month and he often forgets. He has no other significant medication history and take no regular medications. On examination, he appears anxious but cooperative. Vital signs with normal limits and mental states examination reveals paranoid delusions but no hallucination or thought disorders. He denies any thoughts of self harm, suicidal ideation, or intent harm to others. It's decided that he would benefit from admission. Which one of the following is most appropriate plan? So, this is the question. So, what do you think? What do you think, doctors? Okay, most are going with this. Let's check. Yes. Why patient is forgetting drugs, right? Here the most appropriate management is switch to risperidone as a depot injection. Why this patient has demonstrated poor adherence or to oral medications, because in questions they are mentioning patient is forgetting to get this risperidone, but otherwise in previously patient is well controlled with that, right, and risperidone. So the only problem is adherence, right? So in that case the best option here is we can give it as an injection, and which has led to relapses in schizophrenia symptoms. According to current therapeutic guidelines, depot antipsychotic injection should be considered for patients who have difficulty adhering oral medication regime. Okay, so next one. A 20-year-old man present to the GP clinic with his parents with a report a 6-week history of odd behavior. Over the period, they report their son has become obsessed with the notion that he's being watched by governmental spies. Over the time, they have also found it more difficult to understand and maintain the conversation with him. Upon further questioning, his parent notes a 6-month history of withdrawal behavior from their son, um, culminating in him withdrawing from his architecture degree and losing his part time job at the supermarket. On examination, he appeared disheveled and agitated. Pulse rate 90, blood pressure 120 by 8, respiratory rate 16, and SpO2 98, and conversation is disjointed and centers uh, thematically on the belief that he is being monitored by government spies and target of an investigation. A full organic workup, including urine drug screen, is unremarkable. Which one of the following is most likely diagnosis? So, what do you think, doctors? We got C's and we got A's. Okay, most of going with C. Let's check. Why? Here, schizophrenia is most likely diagnosed in this case. The patients present with both positive symptoms, paranoid delusions, disorganized speech, and negative symptoms like social withdrawal, right? His 6-month history of withdrawal behavior followed by 6-week period of paranoia active symptoms fulfill the diagnostic criteria according to the DSM-5, right? So yeah, let's do few more questions and stop the session, right? Okay, a 24-year-old woman seen by psychiatrist for review of her paranoid schizophrenia, for which she takes risperidone and 3 milligram oral twice a day. She was first treated with olanzapine following initial diagnosis at the age of 20. However, this agent was switched to risperidone 3 months ago after she experienced troublesome weight gain from olanzapine. Over this period, there has been no emergence of psychotic symptoms. However, she has been feeling fatigue and complained that her periods have become irregular. She reports some mild breast tenderness as well as nipple discharge. Subsequent investigation revealed a serum prolactin level is increased. The psychiatric explained that her symptoms are likely side effect of her risperidone and that a further medication change must be warranted. Switching which one the following the suitable. So this is a very famous question for AMC, right? The weight gain and prolactinemia. Sorry. Yeah, because the aripiprazole is better because it has the less amount of the psychotic adverse effect, right? Here, the satisfactory second line schizophrenia treatment for patients who are experiencing troublesome side effects with risperidone. So, hyperprolactinemia is a common side effect of certain antipsychotic, including risperidone, and can lead to symptoms such as menstrual irregularities and galacturia, right? Okay. A 19 years old woman admitted involuntarily to the psychiatric inpatient ward with a 6-month history of behavioral disturbances and impaired social functioning. According to her new housemate, she moved across the country in the attempt to escape pursued by an international criminal gang. Recently, she destroyed all by her electronic device with the hammer, and she's believing they were being used to record her activities. She reports often hearing the voices of her enemies outside her bedroom window, and she has not left the house in over a month and has stopped showering. She denies suicidal or homicidal ideation. She does not have any significant psychiatric history. However, her medical history includes obesity and hypertension. On examination, she appears anxious and poorly groomed. BMI 34, and what is most appropriate antipsychotic for this patient? What is this, doctors? What is, yes, you are going with what? Good. Here, aripiprazole is a second generation antipsychotic with a favorable metabolic side effects profile, making it suitable for patients with obesity and hypertension. So, what you should decide to have to remember that chart, right? Yeah. Okay, next one. A 31-year-old man present to the GP clinic accompanied by his family with 2 months history of behavioral changes. He believes he can control the weather and his cows are talking to him, and that the television and sun are sending him messages from God, and he has a medical history of type 2 diabetes mellitus. His only medication is metformin. He works as a farmer. On examination, he appears disheveled with poor personal hygiene. Pulse rate 88, BP 125/80. Then speech is disorganized and difficult to follow. BMI 29. His property has fallen into disrepair. Which one of the following antipsychotic medication? So type your answers in the chat. Okay, I think now we are getting like same kind of questions, right? Yeah, let's check next one also like that one. We have to do this question. Let's check this one. 42-year. I have selected something. Okay, I'll find. A 42-year-old woman presented to the GP clinic with involuntary movement in her involuntary movement. Is that in mouth and tongue that have been present for the past 6 months. She has history of treatment-resistant schizophrenia and has tried multiple antipsychotic over the past 10 years, including risperidone, olanzapine, and haloperidol, with yeah, sorry, 1 minute. With inadequate response, she's currently taking aripiprazole and reports ongoing positive symptoms affecting her quality of life. She has no other significant medications history and no other regular medications. Examination, she appears well with vital signs within normal limit, and there's a visible coriform movements of the her lips and tongue, which was when she distracted. Her psychiatric has changed to tardive dyskinesia and considering treatment option. Which one of the following is most appropriate next step? Switch to clozapine, increase aripiprazole, start terbinafine, and be in benzophine, switch to haloperidol. So what do you think? So what is the answers, doctors? You are going with this. Okay, let's check. Okay, let's check why. Why? This the patient presented tardive dyskinesia and the content of treatment-resistant schizophrenia. The management of this complex situation require careful consideration of both the movement disorder and the underlying psychotic condition. Let's check why. So we all know that clozapine is a gold standard treatment for treatment-resistant schizophrenia and has a lower risk. And in patients with both treatment-resistant schizophrenia and tardive dyskinesia, optimizing antipsychotic therapy take priority over specific tardive dyskinesia treatment as switching to a lower risk agent stabilize or improve the movement. Here, switch to clozapine is most appropriate, it's a gold standard for the treatment-resistant one, which this patient has demonstrated by failing to respond to adequately or multiple antipsychotic. Importantly, clozapine has been lowers risk of antipsychotic. Yeah, you can read it later, right? You have to do I think 24 questions in antipsychotic and you can do it, right? So we have covered most of the questions as well. So yeah, please make your own note what is the DSM-5 criteria and what are the symptoms, okay, positive, negative, and cognitive symptoms, and you should know when how long treatment should be present, okay, to diagnose schizophrenia, and at the same time write down these other diseases like brief psychotic disorder. Please write down this, okay, brief psychotic disorder, schizoaffective, and what is the other one? Schizophreniform disorder. Okay. When writing DSM-5 criteria, you have to write down that as well. Then the next most important management, and you should know how we manage the acute situation. So we have discussed it. Then what is the long-term management to prevent relapses? That is antipsychotic treatment. And then you should know how long we should use the antipsychotic. You should know when we use 2 years and when we use 1 year. Okay, then if you are continuing drug and still patient is coming relapses, you have to check why this happening. So you have to check adherence and adverse effect and everything. Okay. And if you want to, like, if the patient is having adverse effect and you want to switch to drug, then you should know how we should switch this drug. And for the adverse effect, you should know what are the drugs. Like usually overall the aripiprazole is the best one, and you should know who has the most cardiometabolic effects, and the drugs that I mentioned, like you must know, like risperidone, clozapine. Now I can't remember the drugs that I discussed when I was like showing that the table. Okay, so you have to know each and every adverse effect for those main drugs, and you should know how we treat extrapyramidal side effects because these are very important. And then you should know how we should treat treatment resistant schizophrenia. Okay, so like those are the main things, and please do the e-medicine question, then your concepts will be clear out more. Okay, and thank you so much, doctors. Now I'm so tired. I had to stop this session. Yeah, I need to get some rest because I was talking for almost 7 hours. Thank you so much, doctors, and we will meet tomorrow. I can't remember tomorrow's topic. I'll check and tell you. Okay. Thank you so much. Yeah. Okay. Okay. So have a Good day, doctors. Bye bye. And I got so much messages in Telegram, and I'm so sorry I couldn't reply it like as soon. But now after this, after this session, I'll reply you all. And so sorry for the delay. Okay, because I'm getting so much messages and I can't, it's very hard to reply everyone at the same time. Okay, and sorry for that. If you like, don't think like I'm ignoring. I'll reply. Okay. Yeah, and please, doctors, check the usually the file sections because most of the guidelines are there. And like if you can't find, just you can type in the search button, like as example the hemorrhoids, then you will find out where hemorrhoid topics is, like even in PDF also. Then it's very easy. If you can't find anything, I can send from the TG as well. So thank you so much, doctors. Okay, bye bye. I'm gonna stop the session. I'll upload it in later. Thank you.